Let me know when we have everybody in.
Should be good to go.
Okay. Hello, welcome to this session of the 2023 Culture of Data Conference. Thanks for joining us. My name is Carol Schmidt, and I'll be moderating this session. We also have Dennis Wright, who is managing the Zoom and making sure the tech is running smoothly. You're all muted now, but if you have a question during the Q&A session, feel free to unmute. You can also use the chat box if you have questions or need anything else. If you're comfortable doing so, add your pronouns to the Zoom name by clicking on the 3 dots on your video square and selecting rename. First of all, I'd like to say this session has been generously sponsored by Trailhead Institute. So I'd like to thank them for their contribution for the conference. I'm pleased to introduce Jillian Grant to share a few words, and I hope she's on because I didn't check that.
Carol, I'm here.
Yes, hello. I didn't even see you up in my right corner.
I know there's a lot of people here. Thanks, Carol. Hi, everyone. My name is Jillian Grant. I use she, her pronouns. I work at Trailhead Institute as a program manager, and Trailhead's really honored to sponsor today's session with Nancy, Jerad, and Kimberly. It's really good to see you. I saw you at Public Health in the Rockies, so it's good to see you again. We're really excited to be sponsoring this session about discussing new ways to promote inclusion in data collection and data governance. Our work as a nonprofit public health institute is guided by a vision of Colorado where everyone has an opportunity to be healthy and live in a healthy environment. When we consider how data can nurture this vision, we know that its collection and use must be grounded in inclusive practices that honor autonomy, respect, and accountability to the people and the communities at the heart of data collection. So thank you to our presenters for joining us today to talk about the importance of honoring tribal sovereignty and Indigenous data governance and how we can respectfully collect self-reported information to honor diverse identities. I'm excited to be here. Thanks.
Thanks, Jillian. We have 2 presentations during the session. Each will be 20 minutes with a 10-minute Q&A afterwards. We'll have a 5-minute break between the 2 sessions. The theme of this session, as Jillian said, is Reexamining Demographic Data Collection and Data Sovereignty. What's really interesting is I found out yesterday that the feds are revisiting their current race ethnicity questions and talking about, right now it's what is your race, what is your ethnicity? Well, they're talking about putting that together and then having a longer set of questions where you talk about your country of origin. So it should be interesting. So our first presentation is Acknowledging, Understanding, and Abiding by Tribal Sovereignty in Indigenous Data Governance, presented by Kimberly, Blackhorse, and Jerad, Kozey. And with that, I'm going to give you the floor, Jerad and Kimberly.
Thank you so much, and welcome everyone to Kimberly and I's presentation. My name is Jerad Kozey, and today we'll be talking about tribal data sovereignty. So as we move through the presentation today, there are 5 topics that we'll be focusing on. The first will be tribal sovereignty as a whole, how tribal sovereignty moves into tribal data sovereignty. Then we'll discuss tribal sovereignty affirming practices that are currently in action. Then we'll go over a few efforts that are going on in Colorado today, as well as give a few pointers on some good ways to move forward in a good way towards more tribal sovereignty affirming practices. All right, so let's talk about tribal sovereignty to start. So we start our presentation with a picture for all the visual learners out there. So in this picture, we see tribal lands across the continental United States prior to colonization. Sovereignty of the tribal nations here, although intact far before the writing of the US Constitution, now today is determined and recognized through Article 1, Section 8 of the US Constitution. Now, I'm not going to read the article directly, but I will summarize by providing the stipulations to being recognized federally. The tribe must be able to demonstrate the following. 1, a distinct community since historical times. 2, political influence over those members. 3, there needs to be membership criteria. Now, this may or may not include something like blood quantum. And 4, a membership that consists of individuals who descend from a historical Indian tribe and who are not enrolled in any other tribes. Now, if a tribe does meet these criteria, the US recognizes that tribes are a distinct entity outside the US and other foreign nations, an entity that is permitted to establish and pass legislative rules and laws outside of the United States. So continuing on with the images, here we have another image of the current tribal lands within the United States. So as you can see in the picture, the area of the tribal lands has shrunk significantly since imposing Article 1, Section 8. And in the initial image, we saw the American Indian Alaska Natives used to sovereignly control 100% of what is now the United States. And at that time, roughly 100 million American Indian Alaska Natives lived on those traditional homelands. However, today, in this image, we see tribal lands making up only 56 million acres of the 2.27 billion acres that is owned by the United States. What this means is now the 3.7 million self-identified American Indian Alaska Native peoples in the US only have sovereign control of roughly 2% of the entire United States. Now, the reason I share these numbers is so you can understand the dire need to recognize tribal sovereignty and its connection to American Indian Alaska Native populations having the opportunity to determine their own futures that hopefully will include their own ceremonies, cultures, languages, and ways of knowing and doing. All right, so now that we have a better understanding of sovereignty, let's look at what tribal sovereignty actually means. So what tribal sovereignty really means is that individuals, organizations, and other governments are required to respect a tribe's autonomy, particularly in regards to their governing authority over tribal land, peoples, and jurisdictions. It also includes respecting community cultures, customs, and protocols. Protocols, for example, like recognizing government hierarchy. And it is because of this sovereignty that being American Indian Alaska Native means more than just race or ethnicity. It is also a political status. Native American citizens who are also enrolled members of a US federally recognized tribe are considered dual citizens. This political status coincides with US federal trust responsibilities, as well as demonstrates the importance of acting in accordance with tribal laws, rules, and policies when working with American Indian Alaska Native peoples. So speaking of federal trust responsibilities, let's take a look here at what the government's responsibilities are to tribal sovereignty when working with federally recognized tribes. So this includes things like adhering to the treaties. So this means the federal government is obligated to adhere to government treaties signed by tribal nations and the US government over the course of this country's history. It also has to do with protecting and enhancing the tribes. Now, this means to provide services required to protect and enhance tribal lands, resources, and governments, which includes the access and availability to economic and social programs that increase the standard of living and social well-being on tribal lands. And then lastly, the third responsibility we see here is respecting the autonomy of the tribes. Now, this not only includes respecting their right to govern themselves, but also the duty to consult. Now, in 2010, President Obama created the duty to consult and the US's policy of tribal consultation, which require governments to consult with Indigenous and tribal communities prior to taking action likely to affect their traditional lands or their peoples. Now, this allows for tribal governments to express their thoughts or concerns, as well as includes them in the decision-making processes. All right, so now that we know a little bit more about tribal sovereignty, it's time to dive into the data stuff. But before we talk about how sovereignty factors in, we first need to know what data we're actually even talking about. So let's look at what it is and what makes up Indigenous data. What we have to understand here is that data collection and data sharing are not foreign concepts to Indigenous people. Indigenous people have been data creators, users, and stewards since time immemorial, using data to inform their instructional practices and cultural principles. As for the data itself, the information we're talking about here is not only individual information, but collective as well. Indigenous cultures place extreme importance on respect, relationships, relationality, and holism. Therefore, when we look at Indigenous knowledge systems, and data, we need to know that they are communal in nature, an aspect that needs to be considered during its collection and translation. But to put it plainly, Indigenous data is any facts, knowledge, or information about Native nations, including information about tribal citizens, lands, resources, cultures, and communities. This includes information ranging from anything like demographic profiles all the way down to social media activities. So as we can see, Indigenous data can be very all-encompassing, which is why there is such a need right now for understanding and recognizing tribal data sovereignty. So what is tribal data sovereignty then? The definition here states that tribal data sovereignty means that tribes have the right to self-govern the collection, ownership, stewardship, and application of their own data. And this is the definition we're going to use. But what we need to understand is, at its base level, data sovereignty aligns with the concept of interrelationships. Interrelationships which include people's sacred histories, ancestral homelands and languages, and cultural traditions. Now, I want us to really think about the definition here while I say this next comment. Native nations and tribes are sovereign political entities who have inherent rights which include the right to data about their people, lands, and resources. However, at present, the majority of Indigenous data is held by non-Indigenous governments, institutions, and agencies. Now, this isn't necessarily an immediate issue, but the flaws in these relationships became quite apparent during COVID-19. There were gaps in data sharing resulting in gaps in care and gaps in provisions being supplied to areas that really needed it. It also highlighted the mistrust evident between tribes and the government bodies, and the need to begin repairing these relationships for the future. So this is why tribal data sovereignty networks are hard at work to develop and perfect data principles that better represent the respective rights of sovereign nations and tribes. And to accomplish their goals, they've gone ahead and increased tribal member participation in data governance activities. This not only empowers tribal voices, it reinforces the rights of tribal members to engage in the decision-making processes, thus highlighting Indigenous values and collective interests in these processes. So in doing so, we do away with the previous consultation-based approach to research and data collection and adopt a values-based approach, which promotes respect, equity, and self-determination. That said, the work isn't over. Tribal data sovereignty is still something of a foreign concept to some, meaning continued education is a critical component to ensuring tribal data sovereignty is followed and all tribal sovereignty rights are recognized. That said, there are a few quick and easy things you can think about to help you and your work abide by and affirm tribal sovereignty. And these are: 1, only a tribe has the sovereign right to determine how their data is collected and used. 2, when someone is reporting on or about American Indian Alaska Native peoples, there needs to be meaningful partnership and consultation with tribal leaders on how the data will be analyzed and interpreted. 3, tribes retain ownership of their data, full stop. And lastly, tribes must receive equitable access to data needed to inform tribal practices and perform governmental duties. Now, it is at this time that I'm going to pass the mic over to Kimberly Blackhorse, who will take us through tribal sovereignty practices in action today.
Thank you, Jerad. So let's continue the conversation and discuss how implementing tribal sovereignty affirming practices can be done. So it is recommended to engage in meaningful communication, which is transparent and authentic. Part of this is having a point of contact, such as a tribal liaison who can assist greatly with consultations that are meaningful and intentional. Tribal liaisons are aware of cultural norms, tribal government systems, and they are able to coordinate and strengthen tribal relationships with respective departments. So to speak, they are the key components when including tribal governments into the states or other government programs, and the same goes for NGOs. When considering the intricacies of abiding by tribal sovereignty, it is important to create set-aside funding for tribal governments and urban Indian health organizations. So both do not compete for the same funding. In this actionable step, it will strengthen relationships within the American Indian and Alaskan Native communities and not create any further divisions. When data is concerned, another key component to this equation is including tribal epidemiology centers, which we will discuss later. And also adhering to American Indian and Alaskan Native best practices when collecting, analyzing, and interpreting AIAN data. So let's move over to the next slide to discuss a few recommendations related to data collection. So before I start with a few recommendations, I think it is important to acknowledge the history of research and the improper techniques that occurred when collecting data on or from Indigenous people. So this can briefly explain the inherent mistrust to researchers, research teams and institutions, and even the theme that data is used against tribal communities and not for tribal communities. For example, negative framing of interpreting data. Therefore, I would like to present a few recommendations when collecting data on AIA and population that honor tribal sovereignty. First, adhering to data use agreements that respect tribal sovereignty and the governance of tribal data, as my colleague Jerad has mentioned. In addition, I would like to recommend, when possible, add AIAN in combination with other races as compared to AIAN alone. Also, when presenting data to or for tribal communities, let's go beyond the quantitative data presentations and think about incorporating Indigenous research methodologies, such as presenting with storyteller sections, with pictorials, or information from circle work. When integrating Indigenous research methodologies, it is of vital importance to include tribal communities in every step, from the development to the execution of the presentation. And lastly, it's important to acknowledge strength-based approaches that within a community, this provides tribal communities the opportunities to highlight the positive acts within their customs and traditions. So let's look on how to incorporate tribal epidemiology centers, or TECs, within the work. So under the Health Insurance Portability Act, HIPAA, tribal epidemiology centers are designated as public health authorities and authorizes TECs access to available data. They're able to elevate the health status of tribal and urban AIAN communities across the country. To do so, they require access to relevant and raw data that is collected, monitored, or evaluated. That which impacts tribal AIAN members, tribal organizations, tribal urban Indian health organizations. So within the US, there are about 12 TECs, which frequently collaborate with other jurisdictions such as local, county, state, federal agencies, and public health entities. And this also includes private entities. In Colorado, there are 2 tribal epidemiology centers that interact with Colorado. The first is Albuquerque Area Southwest Tribal Epidemiology Center, Aztec. Serves the Southern Ute Indian Tribe and the Ute Mountain Ute Tribe, which is a part of the 27 communities that Aztec serves within the states of Colorado, New Mexico, and Texas. The additional TEC, which serves Colorado urban Indian organizations, is the Urban Indian Health Institute, UIHI. Among the many resources offered to urban Indian organizations, UIHI provides community health profiles, which provide a snapshot of urban AIAN health services throughout the nation. So you may be asking, what is going on in Colorado to implement tribal sovereignty affirming agreements? Well, let's go to the next part to explain the efforts within Colorado. So what we'll be explaining is the tribal sovereignty that occurs within the state and the state departments. The state of Colorado recognizes tribal sovereignty and the importance of honoring the government-to-government relationship. To provide some history between the relationship, in 1976, the Colorado Commission of Indian Affairs, CCIA, was created by the Colorado General Assembly. CCIA is the official liaison between the state of Colorado and the 2 federally recognized tribes, which again are Southern Ute Indian Tribe and the Ute Mountain Indian Tribe. In addition, CCIA also works with the additional 46 contemporary tribes which have historic ties to the state of Colorado. To formally acknowledge the government-to-government relationship, CCIA created a state tribal consultation signed document. The signed agreement establishes the formal communication between the state government and tribal governments. Currently, there are 5 state departments that have agreed to adhere to the official state tribal consultation guideline. CCIA further supports enhancing a structure within the state government and departments that respect and adheres to tribal sovereignty affirming practices. In terms of implementing tribal data sovereignty practices, CCIA uses data sovereignty principles and provides adequate staffing to do so. They also have supported the hiring of state staff to implement tribal sovereignty affirming practices within CDPHE. Now that we have provided a high overview of what is occurring with the state level, let's move on to discuss what has been implemented. I will be speaking from the perspective of from CDPHE, as I am an employee of CDPHE. And I hope CDPHE can show what can be done by creating a tribal team at a department level to respect tribal sovereignty and implementing tribal sovereignty affirming practices within the department. So, as stated previously, I will be speaking from the actionable steps from CDPHE has taken to respect tribal sovereignty. The tribal team at CDPHE is knowledgeable about the intricacies of tribal sovereignty rights and the uniqueness of tribal governments and the AIAN customs and norms. Overall, the tribal team helps promote health equity and respects tribal nations as sovereign nations. The actionable steps CDPHE has taken were the development of a tribal team, which includes the hiring of tribally associated positions. This includes a tribal liaison, the hiring of tribal health data specialists. This includes myself and my colleague Jerad. And also the team includes a tribally focused contract monitoring team. Secondly, the Environmental Justice Task Force has dedicated time to work with tribal positions within the state, as well as community members to ensure tribal protocols are followed. And lastly, the collaboration with tribal epicenters, which provides access to data and promotes health equity and addresses the Indigenous social determinants of health with our tribal and AIAN community partners. So, moving on in a good way. We want to leave you with a phrase, moving forward in a good way, which encourages the use and practice of thinking and integrating tribal data sovereignty within health equity. When tribal sovereignty rights are added to the conversation, it recognizes the importance of tribal autonomy, which is important when addressing Indigenous social determinants of health. When AIAN and tribal voices are included, it is a step in the right direction to create tribal relationships that are authentic. In fact, when AIAN voices are brought to the table, it further strengthens the external partners' practices of cultural humility and respect of tribal sovereignty, and addressing the unique differences seen in Indigenous social determinants of health. In a sense, it provides external partners to be collaborators instead of authoritative entities. So at this point, we'd like to thank you for partaking in this pull-out session. We hope that your next actionable steps will include the acknowledgement of tribal sovereignty rights in your current and future data practices. Jerad and myself are open to collaborations as we work every day to enhance our data relationships with tribal governments, the AIAN organization partnerships, and working internally within our department to create tribal sovereignty affirming practices and policies regarding AIA data sets. So we'd like to open up this time for any questions or comments.
And you can put questions in the chat if you'd like to, but again, go ahead with your questions.
It's a quiet room.
I can ask one just to get people started because sometimes they're really, shy about saying things. But can you give me an example of a project that you've worked on in the state that you're the most proud of?
Kim, do you want to take this, or you want me to?
What if we have enough time, we can both mention one, because there are quite a few projects since Jerad and I were hired that we've been working on so diligently.
Yeah, and I think I'll start by just mentioning one specifically. Currently, we're working with the COVID-19 wastewater surveillance program to develop one of our first memorandums of understanding for data sharing with the Ute Mountain Ute Tribe regarding COVID-19 cases, as well as viral loads in the water. It's a pretty remarkable project that we're working on, and being able to write that memorandum of understanding and contributing our own ideas and terminology is pretty special, at least for us.
Another thing too within CDPHE that we've been able to do is create more of a collaboration with the tribal epidemiology centers, as they are public health authorities and they were recognized by CDC as public health authorities. So with our positions, we're able to increase the collaboration and trust within the not only the AIAN community, the American Indian and Alaska Native community within the state of Colorado, but also with our tribal partners, which are the Southern Ute Indian Tribe and the Ute Mountain Indian Tribe.
Other questions for Kimberly and Jerad? Come on, you guys. I can always ask a million questions. I don't like the sound of my own voice.
Another thing that's going on, referring to the tribal consultation guides. So there are about 5 departments that have agreed to adhere to the official state tribal consultation guide that was developed by CCIA. And those departments include Colorado Department of Public Health Environment, Colorado Department of Human Services, Healthcare Policy and Financing, the History of Colorado, and the Colorado Department of Education. And as we all know, there are more departments within Colorado that we are hoping that they will also join the efforts to be a part of the state tribal consultation guide.
You're getting some nice kudos on here. And is there a project, process, or work you want to work on but haven't been able to do so yet?
Where do we start?
There's so many.
Yeah, I think one of the things that we would like to instill is sort of a statewide training regimen to inform individuals who work with data collection and data stewardship on not only just the public health authority title in which, you know, techs have at this time, but just informing individuals who work in these realms about tribal sovereignty and what tribal data sovereignty really means, so that moving forward, when we enter into agreements, you know, positions, I know this is going to sound counterproductive, but positions like Kimberly and mine aren't necessary anymore, because we're a more educated collective when it comes to data stewardship.
Another part of that is bringing on interns from the academic area, from community level, to be a part of what we're doing and be more visible in what we're trying to do at the state of Colorado level. There has been a national movement as well as an international movement to create principles for tribal data governance, Indigenous data governance. And within the case of the United States, it's the Indigenous Data Sovereignty Network, whose goals are to empower Indigenous people through self-determination and the promotion of sovereignty affirming practices. So when we speak on data and the collection of data, there would be principles that would be used that would be more well-versed, more well-used within the data realm.
I would just like to add to that point. I think Kimberly's being a bit modest. She was part of a team that presented to the CCIA suggested principles in which to work with data on behalf that affirm tribal data sovereignty. So I'd just like to give her a little bit of a kudos and a name drop there.
And you have another question if you want to answer it.
Yeah, I think I saw that. The
Yeah.
Colorado, how do tribal governments around Colorado currently receive healthcare data? I'll start off by there are a number of public facing dashboards that present this data, but when we're talking about more specific data requests, especially when we're looking at AIAN populations, namely in the Southwest, where the 2 federally recognized tribes reside, those requests generally actually come through Kimberly and I, in which we filter through the stewards, which house the data. We compile it according to their requests, depending on what they're looking for, so that it's as informative as possible for them to put it directly to informing their practice. So those requests actually come to us, and then we do the legwork before sending them back with a document that answers their questions.
I think unless there's any more questions, we're going to take a 5-minute break to give everyone a chance to move around and re-energize for the next speaker. We encourage you to get up from your chair and move around, or use this time for whatever you need so you can join us in the second half. And we will begin in, it's a 5-minute break. Okay. So we'll reconvene at 1:40. Oh, but you got one more question here. You do have another minute or so. Can you read that, Jerad?
Are there restrictions to using AIAN healthcare data on public-facing dashboards? Yes. Kim, do you want to take this one?
Sure. So we kind of mentioned this within the slides, referring to best practices and with tribal data sovereignty. So tribes have the right to govern their collection, the ownership, and the steward and application of their own data. They own their own data. So in the past, if we refer to Arizona State University, there was an incident where tribes were not aware that their data was being used at the institution of Arizona State University. And it was used without their knowledge, and the collection the data belongs to the tribe, essentially. So without having tribal information, especially within the state of Colorado, because it's going to be different with every state, within the state of Colorado, the 2 federally recognized tribes, the Southern Ute Indian Tribe and the Ute Mountain Ute Tribe, have a voice in how the data is going to be presented. Especially, yes, I am referring to the Havasupai people, but within Colorado, they have jurisdiction over how the data is going to be collected, owned, and stewarded, because it is their data. And within public-facing dashboards, within the counties of Archuleta, La Plata, and Montezuma, federally recognized tribes belonging to the 2 federally recognized tribes are around 1,000. So self-identifiers could be possible. And we do not want that information out, and we want to respect tribal sovereignty affirming agreements and the tribal data governance on their information. So we are actually trying to work with within their State Department, to say that the information is protected and accessible only to the tribal governments and the tribal epidemiology centers as tech to access that data.
And just to add one thing, if you do look at some of those public facing dashboards, we've already been successful in restricting some of this information being shared. One example is EnviroScreen. If you go to that, we have worked diligently with their creators to ensure that what is being shared has been confirmed okay with the tribes, and what hasn't has been restricted actually on the dashboard itself. So you won't actually see that information.
And this is developed also, sorry, in the MOUs. So I don't think Jerad has mentioned this, but we've been working diligently to develop MOUs and data sharing agreements that also respect tribal sovereignty and the governance of tribal sovereignty data governance.
Hope that answered your question.
Well, that was really interesting. I know people, sometimes it's challenging to work with tribal data and to get permission to work with tribal data. So thank you for the clarifications. All right, so it's 1:36. We'll see you back here at 1:45.
Hey, Carol, you there? Or Dutchman, I should say.
I am. I'm just looking up the Havasupai people data, Arizona State, on Google.
Excellent. That's a good way to go. Just double checking the time you want to come back in.
I think 1:45. That gives us 30 minutes. Gives people like 7-minute break.
No worries. And I believe it was what
The-
want to say?
Nancy Wittmer.
Nancy Wittmer? Yeah. And hopefully that'll be enough time.
Mm.
Nancy, are you here?
Yes, I'm here.
Excellent. Will you be comfortable screen sharing with your slides?
Yeah.
Okay. If you want to give it a quick test run, you can. Otherwise, we can start up at 1:45. What would you be most comfortable doing?
I can try right now. It says that I can't share while you're sharing though.
Right, that's
Okay.
kind of what I expected. So I'm taking
Okay.
this off, and I want to make sure that you have access to do so.
Yeah, it looks like I do. There we go.
Perfect.
And then presenter mode. Okay.
All right.
Yikes, it's genetic material with the Havasupai tribe. That's even worse. I mean, it's bad enough if it's demographics and things like this, but it's pretty creepy that they do that.
Yeah, that information, the professor or researcher that originally collected it ended up sharing it with a number of different institutions. Pretty much wherever they got a job, they shared that information with fellow researchers without telling anybody. And I'm pretty sure he just got a slap on the wrist after it was all said and done.
Boy, I thought you got more than a slap on the wrist if you did that with any kind of genetic data, but I may be mistaken.
Yeah, it's I don't know if you're familiar with the HeLa cell situation as well.
Henriette.
Yeah,
Yep.
Henrietta Lacks.
Well, I learned something new today. Thank you. We're down to less than 1 minute. Are you ready? Okay to go. All right, welcome back. Our second presentation is thinking data collection, analysis, and dissemination of race and ethnicity data, presented by Nancy Wittmer. And I'm really kind of looking forward to this, especially since the feds are going to drive us all crazy with their new standards. Go ahead, Nancy. Thank you.
Thank you. Yeah, good afternoon. My name is Nancy Wittmer. I'm a senior research data analyst in Denver Health's Denver Health's Office of Research, and received my MPH from the Colorado School of Public Health and Global Epidemiology, and have worked in public health and the healthcare field for about 7.5 years now. So today I will be sharing about how we can rethink the collection and analysis and dissemination of race and ethnicity data in healthcare to promote health equity. We'll start by exploring why race and ethnicity data matter. I'll briefly describe an organizational initiative that Denver Health has launched to improve race and ethnicity data, and I'll wrap up with thoughts and strategies to continuously improve this data in an effort to promote health equity. There we go. So as a brief overview of Denver Health, we are an integrated academic health system that serves as the primary safety net health system for the Denver metro region. Denver Health is comprised of an acute care hospital, a level 1 trauma center, federally qualified community health centers, school-based clinics, a 24/7 nurse triage line, the Public Health Institute at Denver Health, correctional care, a detoxification center, and the Rocky Mountain Poison and Drug Safety Center. And before diving in, I'd like to acknowledge these key individuals and groups that have really driven and persisted in improving race and ethnicity data at Denver Health, among other socio-demographic characteristics, to help reduce health disparities within our community. So why does race and ethnicity data matter? When we don't know information about our population, we can't see the patterns that may be pointing to disparities in care and/or outcomes. So knowledge is power, and accurate collection of race and ethnicity data can help us to link race and ethnicity information to quality measures, to examine disparities, and to develop targeted interventions. Be responsive to communities by building trust through accountability, showing where gaps exist and where progress toward health equity is being made, and create a culture of inclusivity by ensuring that our workforce reflects the communities that we serve and that patient information is relevant. The need for robust and accurate race and ethnicity data was put on display during COVID-19. So initially, race and ethnicity information were not systematically collected, and we didn't have the information that we really needed to understand which groups were being disproportionately affected. As data improved, we were able to identify groups that were experiencing a greater burden of disease, and were then able to address them while tracking progress to see where improvements still needed to continue. This was also incremental in ensuring vaccine equity and equity in access throughout the entire pandemic. So what about the many healthcare and public health organizations that are collecting this data? What's the problem with what we have? Race and ethnicity data are often riddled with missingness and inaccurate information. We saw this at Denver Health, where even with required reporting standards, we were still missing over 9% of our race and ethnicity data for our patient population. Additionally, our data had many inaccuracies due to our processes not being systematic and information being collected in various different ways, such as by directional observation from registration staff or indirect estimation. And then in areas where self-reported data were collected. We also noticed high rates of other as patients, especially our Hispanic Latino population, did not identify with the few federal Office of Management and Budget racial options provided. So for example, Hispanic Latino individuals that identified as the ethnicity of Hispanic, but not necessarily a race of white or Black, and so other was chosen. A work group at Denver Health performed a root cause analysis to identify the core reasons why there was this missing and inaccurate information. And at first we found, that when using the Federal Office of Management and Budget standards, these aggregated groupings highlighting in these black headings on the top of these groups show that include just 5 racial categories and then an ethnicity of Hispanic, Latino, or non-Hispanic Latino. And many of our patients didn't feel like these categories were representative with how they identified or were confused by the questions and how we were asking them. So often feeling pressure to shoehorn themselves into one of these broad categories. And I know there's a lot of words on this screen, but that's kind of makes an important point about this, that there's all of these diverse groups and many which still aren't listed. For example, the more than 800 American Indian and Alaskan Native tribes. And all of these are compiled into just these few groups. So furthermore, our staff were collecting information inconsistently and through different methods. Some staff didn't feel comfortable asking for this information at all, leaving it blank or guessing. And others didn't know why we were collecting it or how it was being used, which was really challenging if patients had questions. And then additionally, patients didn't know how the information was being used or why we were asking for it, which led to hesitation in sharing it. And so the missingness, inaccuracies, and broad aggregation of these heterogeneous groups of our data stymied our ability to understand the differences and disparities in the communities that we serve. So after months of gathering data, interviewing staff and patients, many rapid plan, do, study, act, or PDSA cycles, and piloting process improvements, in May of 2021, Denver Health launched the Race, Ethnicity, and Language, or REAL initiative, to improve the collection of this data. Since this presentation is just focused on race and ethnicity data, I won't go into the details about other data that were part of this initiative, but we also were working to improve collection around preferred language and written language, as well as country of origin. So as the approach, we implemented a process to systematically collect this data throughout our organization. This included awareness and promotion with a focus on why we were asking for this information. This was done through marketing with educational flyers and posters for both our staff and patients. This was the We Ask Because We Care campaign. And we trained staff on why we were collecting this information, our updated process for collection, and how to ask for this information, including guidance around common patient questions and concerns. We also improved collection methods. So this began with scripting for registration staff, which was driven by feedback and designed via transcreation, which is conveying the same message and concept in a different language. The script followed the new flow of how questions were asked. We started first with ethnic background, which was a new variable that we were collecting, which automatically linked to an ethnicity, which would be confirmed with the patient, and then finally race. We updated and standardized processes. So who's asking, what's being asked, and when, where, and why it is asked, making it consistent throughout our entire organization. These standard protocols were coupled with staff training and ongoing onboarding of new staff. And then we updated our electronic health record system to match the flow of the new script. This was with the added ethnic background question, which includes more than 300 options to choose from, and as well as an expansion in the MyChart patient portal, allowing patients to update race and ethnic information at any time from anywhere with an internet connection. Here's a portion of the script provided to our registration staff. You can see that it starts with providing context to the patient about the following questions, and then moves into the ethnic background, which, if confusing, can also be reframed as family origin. And then from here, the Hispanic, non-Hispanic, Latino variable is confirmed. And then if a racial group is necessary, or if an individual identifies with a racial group, they can then state that here. So we also focused on patient empowerment. This included patient self-identifying, so no more guessing or direct observation or indirect estimation was necessary. This also supported the ability to select multiple races and or ethnic backgrounds, or to opt out and decline to share anything. And with the addition of the new ethnic background variable, individuals could now identify with a group that was more representative with how they see themselves. And lastly, continuous improvement efforts, including evaluation of the initiative, tracking progress on completeness and accuracy of the data, and gathering formal and informal feedback from patients on their feelings towards the process, comfortability sharing this information, and perspectives on how this data is and can be used. And we also created a process to link or map this data to the federal standards and our own historical data, so that we could meet reporting requirements and compare data while also maintaining this robust granular data. And finally, we are continuing to identify additional areas for improvement by understanding the needs of the community and what they see as the utility of these data being. So nearing 2 years after the launch of the program, we have significantly reduced the missing and unknown responses of the broad Office of Management and Budget, Race and Ethnicity categories for our patient population, going from more than 9% prior to the initiative to now less than 0.5% missing. Additionally, our registration staff have seen changes in how patients are choosing to self-identify, and this is reflected in the data as we see individuals change categories and as we look at sort of the overall data and see shifts in the race and ethnicity distributions. This indicated that not only did we reduce missingness, but that we were also improving accuracy. I do want to just mention, though, that our other race category did grow. This may be due to the question being asked after the more granular ethnic background question, and individuals not feeling pressured to identify a race that doesn't resonate with them. However, since we do have this new ethnic background data, we can now supplement our other racial category to better understand the population that we're working with. So in addition to the improvement of completion and accuracy, we're able to get this much more granular data. So under the new ethnic background variable, individuals have now identified over 260 ethnicities. The top 15 are shared here on this screen. And this allows us to see more detailed information, again, especially for individuals that identify other for race. However, as we have begun collecting more complete, accurate, and granular data, we have encountered challenges with how to analyze and report this data. Working to address these issues, we've implemented and identified several opportunities, although we are still very much learning and know that there's many more opportunities and ideas to explore. So one challenge is the need for standard categories so that we can compare data across systems locally, regionally, and nationally, as well as over time with others and within our own system. So opportunities to address this include linking or mapping granular data to broad agreed upon categories. So through input from community and also aligning with other research and government agencies such as the CDC and AHRQ, we have aligned our granular ethnic background variable to the current Office of Management and Budget standards. This allows us to meet federal reporting requirements and compare data between agencies and over time, while also having the ability to analyze and report more detailed granular data. Additionally, as public health and healthcare agencies, we can work with national partners to update and improve shared meaningful groupings so that more granular data can be compared. The Office of Management and Budget, like was mentioned a couple times so far today, is currently seeking public feedback through April 12th, so next Wednesday, on the updates to the federal standards on race and ethnicity categories, which is a great opportunity for our voices to be heard. However, we shouldn't just wait on national organizations alone. As we partner with local and regional groups, we can also work to identify shared groupings that are used at a local level. Another challenge is how we can manage the small numbers when looking at granular data. And so for analysis, this requires an understanding of the tools that can or cannot be used and acknowledging limitations. So for example, multivariate analysis may not, as a measure of association, may not be possible. However, there's still value in sharing frequencies and proportions. And while it's important to reflect on statistical significance, it's also important to reflect on clinical and pragmatic significance, and recognizing that small numbers can still tell us, and often do tell us, very important information. And there's some really great information about this on the We All Count Equity in data science site. And I have a link to this later on in the slides that you can look at. And then with reporting, it's really important to protect the identity of individuals, especially when we're working with small numbers. And this could be done through various data masking techniques. It's also important to know who your audience is. So for example, for clinic-based reporting in an EHR system, granular data is important for clinical decision-making and should be available. However, for larger reporting, such as surveillance or research, reporting on really small sample sizes, especially cell sizes less than 5, may not be appropriate. And so finally, when there are going to be times where we will need to aggregate data, but how can we do this from a position of respect and understanding? So one way we can do this is by engaging with communities and patients in discussions around meaningful groupings related to health. This allows our communities to drive the conversation and define what they feel is important to their health and identity. And if aggregation is needed, we should be transparent about what was aggregated, why it was needed, and how we made the decisions to aggregate groups. This should be documented in how we perform our analyses and then shared in reports, publications, and presentations, so it's clear what the data are truly representing. So I'd like to wrap up with some thoughts on where we at Denver Health and you all can go next as we continue to improve data to promote health equity. First, at Denver Health, we have begun expanding our collection efforts mirrored from our REAL initiative to other types of patient information, providing patients the opportunity to share sexual orientation and gender identity and efforts to understand patient health-related social needs, to better understand the social determinants of health. The more that we know about our population, the more we are able to understand how combined factors intersect and impact health. Second, we also hope to and can work with patient advisory and community groups to define meaningful groupings that are relevant to health. So this may not be a racial or ethnic background grouping, but could include intersectionality between race, sexual orientation, gender, and determinants such as housing, which may vary at a project or program level basis. And in fact, there's probably typically not going to just be one way to group data. And then third, we can also work with federal and regional groups to share feedback on changes needed as we learn more and as definitions shift over time. So one example is sharing feedback with the Office of Management and Budget on the updated race and ethnic groupings. And then once these updates have been made, we can work to implement them to improve data as a larger community. Though even with improvements, a continuous reassessment of the categories should be had and as communities and definitions continue to change over time. And then finally, we can continue to improve and learn more through various resources shared from others engaged in this work. And then most importantly, by listening to community members and partners. So here's, I've included a few resources with links on this slide that you can visit if you want more information. These are just a few of many that exist, but can be a starting point for further exploration. And this last bullet point, we all count, is what I mentioned earlier that can help with small numbers and looking at p-value and things like that. Thank you for joining me for this session. I'm happy to answer any questions, and please feel free to reach out to me via email if you'd like more information or if you have questions that don't get answered here today. Thank you.
And you have a question in the chat. Can you see it?
Let me pull it up. All right, yes. So did you explore what kinds of perceived risks might influence sharing ethnicity or race identification as reported by your patients or communities? So our group, which I acknowledged at the beginning, they did go through various perceived risks. The initiative, I believe, launched in the previous presidential administration, and we had a lot of concern with patients sharing this information and understanding that, you know, if they did share like a country of origin, for instance, and it was, you know, a foreign country, if their information would be safe, because Denver is a safe city, you know, and I think, you know, that's part of the reason why we added the decline to answer choice. And we did see a little increase in that. But we also try to reassure patients that, you know, this data is completely protected and locked down, HIPAA data, although of course there's always the opportunity for any sort of breach. And so we do try to respect that and understand, and if anybody feels the need to decline to respond or change a response at any future time, they're able to do so.
More questions in the chat? Anyone? I think we talked about this a little bit, but how, you know, the limitations of running things like models, but what do you think is the biggest argument in favor of going this route of like not putting everybody in those big boxes and breaking them out this way? What do you think has really informed your work the most?
Yeah, I mean, I think, you know, one of the things is just those big boxes just hide so much diversity between groups, and this is the new OMB proposal is at least breaking out like North African and Middle Eastern from white. But if you think of, you know, the white category and you have folks from the Middle East, and then like Eastern Europe and the United States and Canada, it's so diverse. And so there's just so much hidden information. And so really having this more granular data, and not just race and ethnic information, but also understanding the intersection with other sociodemographic data is really important and key. And understanding that more detailed data really allows us to understand disparities better, and for certain groups to not be hidden. And if, you know, hidden where like, oh, you know, maybe this group of people are showing that they are having less severe outcomes with COVID, but there's a whole group that might just have smaller numbers that are being completely hidden and masked by that grouping. And so really trying to look at that granular data and also the intersectionality with other variables. And then I see another question in here. So when you were linking granular data to the broader categories, did you have challenges with varying or conflicting opinions or guidance on how to link them? Yeah, it was a very complicated process. I wasn't as involved in that process as some of the folks earlier on the slide that I mentioned, but we did use different guidance and models from the CDC, from the AHRQ and other agencies and groups. But there definitely, I think there are certain groups that, fall into multiple categories, and really we tried to just create as many granular options as possible. We currently have over 300 ethnic backgrounds to choose from. And then did our best to link those, but there's more groups that we're constantly adding to those ethnic backgrounds as well, and mapping them has definitely been a challenge because sometimes there are conflicting opinions, but we've tried to do our best to match that with others, and most importantly speak with populations and understand how they identify. But even speaking with populations, they all, I mean, you could ask 12 people and get 12 different answers, right? And so it's really important to try to honor everybody's individual autonomy while also making this data be able to link so that we can compare across.
I have a data geek question that came to me that you're gonna like. It's like, okay, how would you approach the problem of data suppression if we were to move towards these more detailed race ethnicity options?
Yeah, and that's a really great question, because a lot of times, especially as we break down data and bring in more variables and look at, gender identity and housing and race and ethnic background, you really do start to get in just to super small numbers. And it kind of depends on your audience. So, if it's clinical based and there's the opportunity for clinicians to obviously know their patients, that information can be shared. But when reporting that out, it's really important because individuals can be identified when you start having this many things. And so as far as masking certain data, if things need to be aggregated, again, being very transparent about what was aggregated, how it was aggregated, and also trying to work with partners. And, if we have more partners and we have more groups that have these small granular sort of categories, then we can pile more data together and have those bigger numbers that aren't as small and don't need to be masked as much. And so there's a few things, but obviously it's not perfect, and it's always going to be a challenge and a balance. But really trying to honor the autonomy and be very transparent in reporting when we have to aggregate.
It's a good question. Is you see people moving more and more to trying to get local census tract data and tie it to things like, we're working on something now, climate change, for instance. Who's going to be the worst impact by different types of climate change? And so you want super local data, but then if you have to mask it, it's a challenge.
Yeah, definitely.
Hey, anybody else have questions?
It looks like one or two may have just showed up a moment ago.
Oh yeah, the greatest barriers in hard to reach communities. Can you see that, Nancy?
So what are the greatest barriers to collecting data in hard to reach communities across Colorado? So for us, I mean, we're just really in the Denver metro region. And in a way, we have a unique opportunity to collect data because we have patients coming in, and that's where we collect data. And so through our school-based health centers and through when patients come in to see their primary care provider, and through their patient portal, they're able to identify this. And so in a way that really allows us to collect data on traditionally hard to collect data groups, because they're coming to us and giving this information. And so I think that puts us in a unique spot. But there's also, and then I'm trying to read the second part of this question, but to reduce or eliminate these barriers, that, we're also trying, a lot of the training and stuff to our staff was around really trying to standardize how this is asked, and asking it from like really a point of respect and giving the autonomy to the individuals. And so really helping them understand that they can answer this question. They don't have to answer this question. There's no pressure. But really, and then if they have any questions, we trained our staff on common concerns and questions too. And so just really helping, supporting our staff to collect this information and approach it with humility, and really giving that autonomy to the people really helped. And then, again, we're kind of unique in being a healthcare setting where people are coming to us and going through that registration information.
Thank you. And, I apologize. I blew the timing on this because I was supposed to not, I first thought I was supposed to give people a 15-minute break, and I was supposed to leave 5 minutes at the end for announcements, which I didn't. So the schedule, the slides are on Sched. You're going to need a conference evaluation by email, answer the questions. We have a 30-minute break now, and for a recorded walk and talk section, and the next live session is at 2:45. I think I got to my 5-minute announcements. Thank you so much. This was so interesting. I love data. And of course, I think you have links. You can contact these, the presenters with any more questions. I learned all kinds of new stuff today, y'all.
Thank you, well, all three of you, for your presentation. It was, the parts I could actually hear were wonderful. So thank you very much for your time.
You couldn't hear?
I could, but I'm also here. One moment. Let me